Morning, everyone. I'm Dr. Rajesh Kamble here. We are going to discuss today about the scrotum and the penis. Sono. Basically, in practice, any patient who's going to walk into your clinic is going to have two main clinical presentation. Either he's going to have some kind of pain in the scrotum or a swelling in the scrotum. So if you look at various modalities to evaluate scrotal diseases in practice, we have B mode ultrasound and color Doppler, CT, MR, and radionuclide scans, which are used more commonly in the Western countries. Even by the ACR appropriateness criteria, if you go to see ultrasound, B mode ultrasound with color Doppler is one of an excellent tool which has a high sensitivity and specificity, almost scoring a rating of 9 on ACR criteria. So therefore, without any doubt, ultrasound is the modality of choice in evaluating scrotal diseases. We all knew that there are certain limited textbooks which give information about the scrotum. But yes, working in ultrasound department, you can see more, learn more, and listening to this lecture, which I'm going to share with you. So today you can all swear and say that there is so much technological advancement that high resolution, real time, B mode sonography and color Doppler is one of the accurate tool to evaluate scrotal diseases in our day-to-day practice. There are various indications for which a patient might be referred to you in your clinical practice. One of the most commonest one is any kind of acute pain in the scrotum. Second is any kind of trauma. Then certain lumps felt by the patient, it could be a testicular lump or an extratesticular lesion like an epididymis, cord lesion or tunica vaginalis for which the patient might present to your clinical suit. Then failure of the testes to descend into the inguinal canal, and there can be references to search these testes in cases of cryptorchidism. And without any doubt, infertility, the male infertility factors evaluated with ultrasound and Doppler to rule out varicocele. So the first algorithm when you approach a patient of scrotum is take a history like clinician to know the onset and duration of the pain and the swelling. A very important take home here I want to share with you is that whenever you do scrotal ultrasound cases, just don't do scrotum, but quickly screen the abdomen and pelvis, the retroperitoneum and inguinal canal before you do dedicated scrotal ultrasound. I'll tell you the importance of this very, very shortly. So many times you must have seen that in practice, a ureteric colic patients complains of pain in that ipsilateral testes, and patient might be having a ureteric calculus, which might be the real culprit of the pain in the testes. And in these cases, majority of the time, the scrotum ultrasound is normal. So see, in this case, the patient presented with a stone, but here we picked patient presented with a scrotal pain. But when we quickly evaluated his abdomen, we picked up this terminal lower ureteric calculus, which was the culprit for causing this pain. Then second tip is how are you going to approach your cases? So one is without any doubt you require a good ultrasound machine. You're going to avoid cold rooms and you're always going to use high frequency linear transducers almost in a range of 3 to 12 megahertz. Then, as I was telling you, always have an habit to also scan inguinal areas, retroperitoneum, and then do a dedicated scrotum ultrasound. Here, your approach should be very simple. Go from outside to inside. By that, what I mean is that you're going to first look at the scrotal wall. Then you're going to look at tunica albuginea, which you do not see, but if there is a fluid collection, you can evaluate the same. Second, you're going to dedicatedly see the testes, then go superiorly look at epididymis, then the cord structures and tunica vaginalis. So tunica albuginea is this covering which is seen echogenic area seen surrounding this testes. Wall can be seen in the subcutaneous area, testes as seen here. So let's go step by step and see how we can evaluate these lesions. One of the best thing about ultrasound is that you always have a symptomatic versus an asymptomatic side, and hence therefore always divide your screen into two and compare the pathologic side versus the non-pathologic side. Coming to the testicular anatomy, You all know that testes is a ovoid homogeneous organ, seen something like this on ultrasound. And you're always, whenever you're going to evaluate the testes, you're going to take the measurements of the testes in longitudinal and transverse dimension. In fact, in all infertility related ultrasounds, you should always take the volume of the testes. I'll come to the importance of that later. Once you have seen the testes, you have evaluated the scrotal wall, you're going to go at the upper pole of the testes, and this echogenic structure lying here is nothing but the epididymis. So see these videos which show the same, that how beautifully you can see on ultrasound the entire testes, which is an ovoid homogeneous organ. You're going to look at scrotal wall and then shift your attention to the epididymis. Always, as I was telling you, you have a symptomatic versus an asymptomatic side, and you have a median raphe which divides this testes, and hence always you have a symptomatic versus an asymptomatic side. Having said that, you're going to go superiorly and look at this echogenic lesion or a hypoechoic area, which is nothing but epididymis. Here, you're going to rotate your transducers 90-degree to see the always the body and the tail of the epididymis. So your evaluation of the epididymis is incomplete without evaluating the tail and the epididymis. Then if at all there is a fluid collection, you know that this is nothing but hydrocele, which is fluid accumulation in the tunica vaginalis. Then sometimes there can be specific cord pathologies, and cord is one structure which is full of vascular structures like the arteries and the veins, and depending upon the pathology you can evaluate the cord, especially in cases of varicocele. One of the interesting part of scrotum is that different areas of the scrotum have differential blood flow. So as you can see here, that the wall is supplied by the cremasteric artery, the testes by the testicular artery, and the epididymis by the deferential artery. Now this differential flow is very, very important, because many of the time, because of this, even in cases of testicular torsion, you see that the flows around the testes is seen. But mind you, whenever you are evaluating infertile scrotal ultrasound in testicular cases, it's always the intraparenchymal flow where we are going to take a spectral tracing to see whether this testis is ischemic or not. Then a very third important algorithm is that never conclude your examination without switching on color. That is, color Doppler evaluation is very, very important, and therefore whenever you are going to do the Doppler evaluation of the affected side, always go on the unaffected side, set your machine and use the same settings in the affected region. One of the very common observations seen from my side is that we always just see the flow within on color and never take spectrum within the testes. Now, why it's very, very important is that in many cases of partial or incomplete torsions of the testes, you will see that the spectrum, the color flow is there within the testes, but when you take a spectrum, you will see that the diastolic flow is absent, reduced, or reversed, which are usually seen in cases of incomplete torsion of the testes. And therefore, it's mandatory to take spectral in each and every cases of color Doppler evaluation of the testes. How are you going to optimize your color Doppler unit? So your main aim when you evaluate the testes is to pick up the minutest flow within the testes, and therefore to achieve that you're going to minimize your PRF in the machine. Second, you're going to can increase the color gain almost till you get some noise and then reduce it to set the limit of the color. You can minimize your wall filter settings, and this tool which is power Doppler is very, very important, because it can pick up even the minutest flow of the testes, and therefore in cases of torsion, before you conclude, always look at power Doppler or switch on the power Doppler. So see this is the way you're going to evaluate the parenchymal flow which is seen on color, and this is basically the kind of pattern which I was describing, is that Intratesticular flow is always very important. That is basically always testes receives flow during the diastole state of the heart. So you will always get a typical seesaw pattern or a forward flow pattern or a low resistance pattern in the testes. So typically like an umbilical artery spectrum, you will see low resistance waveform throughout the diastole. As against this, whenever you evaluate spermatic cord, you will get typically a high resistance because of the vessels and the connective tissue which is there in the spermatic cord. So the pattern is typically a high resistance where you get sharp systole followed by reduced diastolic flow. Then I was telling to you the importance of color Doppler, that in critically ischemic testes, without switching on color or without taking spectrum, your evaluation of testicular ischemia is very much incomplete. So always before you conclude saying that this testis is TORS or ischemic and has no flow, you can use power Doppler settings in your practice. So this is the way we evaluate the color and the power Doppler in testes.